Good afternoon, everyone. One of the things that I have not been able to address in the clinic is discussing what the role is of the environment. And I believe this is an important question to ask. I'd like to go back in time. So there is an environmental influence in neurodegenerative disorders. And this one looked like ALS. This was recognized more than 60 years ago. In 1945, a disease called ALS PDD complex, or Amyotropic Lateral Sclerosis, Parkinson's disease, dementia complex, was described in members of the Chamorro tribe from the Pacific island of Guam. A similar disease was described in two other places, in the Kii Peninsula of Japan and West Papua New Guinea. So all these islands were in the western part of the Pacific. Now globally, the incidence of ALS is anywhere between 1 to 4 per 100,000. But in these islands, the incidence of ALS was between 100 and 200 per 100,000. So the disease was known to the locals as litico bodig, which translates as litico or paralysis and bodig stiffness. And the interest in litico bodig came about more so after World War II. So in 1945, a group of military doctors saw this disease in Guam and looked at what they were having for lunch. So the primary source of carbohydrate to the Chamorro tribe came from the cycad seed. The cycad seed, as you can see here, was made into tortillas. So in view of this talk, we have told the chef not to serve tortillas for lunch. So these cycad seeds were cut in half and processed into flour and washed multiple times. So the inhabitants of the island knew that if they simply ate the cycad seed raw, they would probably get very ill. So the washings of the flour were fed to chickens. And if the chickens looked strong and healthy, then the inhabitants knew that the cycad, or the flour, was safe for human consumption. So the Chamorro tribes ate the cycad seeds, or the tortillas, early in life. And what the military doctors saw in this island is that women and children, man and woman, developed a disease early in life, and more so later in life, which looked like ALS. Now, BMAA was isolated from the cycad seed, and it was suspected to cause ALS, Parkinson's dementia, Parkinson's disease, dementia complex. And this was found to be neurotoxic in the laboratory. So as you can see here, there is a fruit bat right next to the cycad seed. So if man ate the fruit bat and the fruit bat ate the cycad seed, what you have is a process of biomagnification, wherein you could have increasing levels of BMAA, a toxin, in the serum of the man that ate the bat that ate the cycad seed. So in the laboratory, although mice and monkeys and rats were fed BMAA quickly developed signs of neurotoxicity, the delayed and chronic form that is characteristic of Guamanian ALS PDD complex was never found. So what is BMAA? BMAA is cyanobacteria, or produced by cyanobacteria. It's found in soil and water. And in Toledo, Ohio, I don't know if there's anybody here from Ohio, this is not Onondaga Lake, this is Lake Erie. They are known to have, in certain times of the year, this slimy green film that's seen on the surfaces of rivers and lakes, from which fish, shellfish, and mollusks feed. And so BMAA, which is the toxin, is routinely found in soil. Is that the conclusion? Well, the answer to that is not simple. So in Toledo, Ohio, they banned the use of tap water coming from Lake Erie because it was infested with cyanobacteria. So they did not allow it for drinking or cooking. And some would argue that there are clusters of ALS near lakes that have harmful algal blooms, as in New England. But proximity and associations, they are not proof of causality. In fact, the 2-3 decades after the interest came about with the CyCad seed connection or the CyCad link with BMAA, several NIH-funded research in Guam over that period of time, feeding CyCad materials, tons of CyCad materials to mice, rats, and primates, failed to reproduce a model of chronic BMAA that would link the environment or poses an environmental risk for ALS. So others would argue that maybe it's in the soil. The high levels of aluminum in the soil in Guam may be affecting the neurons in these folks. However, they did check serum, 24-hour urine, nails and hair, levels and concentrations of heavy metals, aluminum, lead, and others, and found that there was no difference between patient and controls. So it appears that more evidence against BMAA were starting to line up. The primates were fed enormous amounts of CyCad or BMA-rich CyCads in orders of magnitude that no normal human consumption, could ever meet. Research also was not able to yield a definite mechanism wherein toxin would target specifically neurons in the brain and in the spinal cord. And lastly, they didn't find a means by which toxin would accumulate in the brain and spinal cord to explain this long latency wherein a child would eat flour made out of CyCad and then in adulthood develop neurodegenerative disease. So the study of neurodegenerative disorders occurring late in life and environmental exposure is extremely difficult. So these risk factors, they add up through the years. And as we go through the trail of environment-linked ALS, it's really quite easy to get lost. So to help keep us on track, I'd like to talk about how other diseases in history have been resolved in terms of causality. I also wanted to mention that it's quite easy to see the forest for the trees and not see, or I should say, not really be able to understand what goes on in totality. And the first example is 1982, Mptp induced Parkinsonism. A cluster of young men, drug addicts, developed symptoms of Parkinson's disease, and this was attributed to the use of Mptp, which is synthetic heroin. Mice and monkey were given Mptp and showed degeneration of dopaminergic neurons in the brain. So here you have Mptp exposure, right, that led to Parkinson's disease. So the causality was fairly clear. The second example is neurolatherism. So these folks from India and Africa, drought-ridden places, this particular grass pea, not the hummus that you'll get served later, but the grass pea that grew were considered food that provided their protein requirements and considered survival food because they grow anywhere. And I read somewhere, you set fire to them, they don't catch fire. So grass pea grows during periods of drought. It contains a neuroexcitatory amino acid called beta-ODAP or BOAA, which under conditions of overconsumption and malnutrition leads to low levels of sulfur amino acids, so methionine and cysteine. And what they found is that these deficiencies cause degeneration of motor neurons in the spinal cord. So these folks who have neurolatherism, they have atrophy of their gluteal muscles. You know, they walk in the balls of their feet. The legs are very atrophied. So again, a relationship was established. Most people in the research field agree that you know, exposure to this particular grass pea L. sativus as the primary source of nutrition did indeed lead to this particular neurodegenerative disorder called neurolatherism. So what is the environmental influence on ALS? This is a major question that I embarked on months ago and has haunted me every day, especially when Rebecca asked me if I'm ready for my lecture. Now, ALS is a disease with diverse presentation at onset. Right? It affects limbs, upper limbs, lower limbs, muscles that allow for speech and swallowing. It causes degeneration of neurons, upper motor neurons in the brain, lower motor neurons in the spinal cord. And now the trajectory of the disease varies as well. Based on the ALS functional rating scale scores, you can see that the decline starts and patients' survival between 3 to 5 years from time of onset symptoms with less than 10% survival in 10 years. So the question is ALS a combination of genes plus environment, or is the relationship between genes and environment more dynamic than we think it is? So this is important in light of the genetic mutations that have been discovered. There's a strong push to do gene therapy. Now, it is known that most ALS is sporadic, but about 10% is hereditary. In other countries like Ireland, 16% is hereditary. So 2/3 of hereditary ALS mutation and 10% of sporadic ALS mutation are already known. SOD1 mutation accounts for 12 to 23% of hereditary ALS, and C9orf72 mutation accounts for about 40% of hereditary ALS, as well as 7% of sporadic ALS. So what I see here is that the distinction between sporadic and familial ALS in terms of genetic mutation is becoming blurred, as similar genetic mutations are being found in these two different, what appears to be seemingly different populations. Current heritability studies indicate that ALS is about 60% of risk of ALS is genetically determined, and the remaining 40% is environmentally determined. So I think in an individual, okay, there's also a blurring of boundaries in what caused that individual's disease. So in an individual, it's 60% genetics and 40% environmental. I mean, can we translate it to that? But then there are genetic variations. And these genetic variations either modify or modulate gene expression in the field of epigenetics. Now, this is a proposed model, disease model of ALS from Dr. Al-Chalabi. This is where the series of unfortunate events happen. The environmental risks and time acting on a pre-existing genetic load is followed by an automatic self-perpetuating decline. Now, another pearl that I think we can derive from the environment is, and this is somewhat of a stretch, so you can stretch your imagination and think of the environment as a drug that is administered, and the drug that would seek to improve health. So that particular example is statin drugs. So statin drugs, they're life-saving. They decrease the rate of heart attacks and strokes. However, 50%, about half of patients develop side effects, and that affects their compliance. So in some, it may be muscle aches, and they're pretty minor, and in others, it could lead to degeneration of muscle and cause atrophy and weakness. So the use of statin drugs can cause these problems, and yet we also know that they are life-saving. So can we predict who develops adverse effect to statin drugs? Now, SLC01B1 is one of the genetic variations, and it reduces the ability of the cells in the liver to allow for the drug to enter the cells. And this type of metabolism happens through transmembrane proteins. So if you detect this particular genetic variation, SLC01B1, that codes for liver transmembrane transporters, it may be able to predict whether one will develop muscle weakness or myopathy from statin use. So again, it looks like the relationship is more dynamic between the genes, genetic variation, and the environment. And this is important in light of the discoveries made with genetic mutations in ALS. So what is in the environment? What is actually the burden of disease-causing factors? So to date, no definite replicable risk factor has been identified. So I will tell you that the next few slides might be painful to listen to. So there are established risks based on epidemiological studies, and age is a major risk factor. So based on Dr. Trio's report, which is a systematic review of literature on epidemiological studies between 1995 and 2011, we know that the mean age of onset is about 62 years of age, and the mean age of diagnosis is about 64 years of age. So there's about 12 months of lag time between time of onset and the time of diagnosis. The second risk factor is being male. So the male gender is associated with 1.5 times the risk of developing ALS compared with female gender. And after menopause, the incidence of ALS becomes nearly equal in both sexes. Now, smoking is also an established risk factor for ALS. And this is a large longitudinal prospective study which examined the relationship between smoking and ALS in 5 well-established large cohort of US men and women with study-specific follow-up ranging from 7 to 28 years. So they had over 500,000 men and 500,000 women. And from there, they were able to obtain 832 participants with ALS. So they did find that smokers had higher risk of ALS than never smokers, and that cigarette smoking was associated with significantly higher risk of ALS, but the risk of ALS did not increase with years smoked and number of cigarettes smoked per day. So what this tells me is that yes, there are more smokers, and yes, smoking earlier in life may be a bigger risk for the smoker. However, when they followed these patients, they didn't find that it was related directly with the number of years smoked. So it didn't appear significant how many pack years the person smoked. It also did not appear significant as to the number of cigarettes a person smoked in a day. So what this tells me, it's not that smoking is not a risk factor. Yes, it is a risk factor, but smoking is not the beginning and the end. There's more to this story than smoking. Military service. So there were 6 cohort studies published between 2000 and 2005, and these suggested that military service was associated with early onset sporadic ALS. Among these, 4 studies reported an increased rate of ALS incidence among US military veterans deployed to the Persian Gulf War between 1990 to 1991. And these were compared to veterans deployed to other areas. Now, during the first Gulf War, 1990 to 1991, there were oil fires. And the concern was whether these oil fires threw huge aerial doses of toxin in the air, which is selenium. Now, a positive association between military service and ALS has been suggested, however, not enough to make definitive statements. In the last decade, there have been 2 major epidemiological studies conducted in the US, and some of them also capture the story behind ALS and military service. So the first one, major study in the US, was launched in 2007. This was the Geneva study. Geneva stands for Genes and Environmental Exposures in US Veterans. So genes and environment, they found that in this cohort, 5 to 10% of ALS could be explained on the basis of genetics. A retrospective study was conducted to obtain lifetime occupational history, which means the data was collected about past history to try to explain the present condition of ALS. So there were over 600 cases of ALS patients enrolled in the National Registry of Veterans, and over 900 controls were enrolled from the beneficiaries. The participants were asked about jobs held for 6 months and longer from the age of 15 onwards. And this was a possible source of bias because recollection spanning many decades may be spotty. They had 3 experts in industrial hygiene rate the various risk exposures depending on particular industry and occupation. And they looked at 30 specific exposures related to military service, such as vaccines and riot control substances. So what they found was that the 3 raters, their reliability was highest with agreeing on lead, hydrocarbon solvents, and viral agents. So these raters seem to rate similarly for lead, hydrocarbon solvents, and viral agents. The industries with highest exposure, number 1 was manufacturing, number 2 utilities, number 3 healthcare, and the last was military with non-combat jobs. So I wanted to just make a note here that lead exposure has declined since the phase-out of leaded gasoline in 1973 and lead-based paint in 1978. This has led to a 10-fold decrease in lead exposure from 1978 to 1997. And as far as hydrocarbon solvents, it seemed to, all 3 raters appeared to agree that exposure to hydrocarbon solvents classified by these individual raters were one of the highest in terms of industry and occupation combinations. So hydrocarbon solvents are the output of petroleum refineries, and gasoline, kerosene, oil fuels. Now, the selection bias could have occurred because their controls came from VA veterans beneficiaries. So you want to ensure proper randomization, and you want to be able to achieve that at the end of the study. If the control population is not representative of the population intended to be analyzed, but if there are some similarities between the control and the population that you're studying, then that could be a source of bias. The second major study in the US was launched in 2010, and that is the National Als Registry, which was created and tapped 2 sources for risk factor surveys. First one was a national administrative database, Medicare, Medicaid, Veterans Administration. And the second one identified cases captured by their web portal. So the preliminary results of this National ALS Registry was published last year. So what they found in this prospective population-based registry is that it really stood out among many epidemiological studies in that it's the largest collection of risk factor data about adults with ALS, and it's more comprehensive than has ever been possible. So this was a prospective study, so instead of looking at past records, these individuals were followed over time. One of the goals is to quantify incidence, prevalence, and demographics. And they examined risk factors for the disease through online risk factor modules, numbering 17, which included cigarette smoking, alcohol consumption, military service, occupational history, and family history. So roughly about 12,000 people registered, and about 7,000 people among those registrants answered surveys. And when I did the math, each one answered about 5 surveys. So all in all, they collected 35,000 risk factor surveys between October 2010 to 2013. And what they found was that most of these who answered the survey were between 50 to 69 years of age. 94% were white. 72% were college or higher level of education. And the participation was, as expected, about half, about 50%. And here, once again, they looked at smokers. So nationwide, you have 41% smokers, but in this ALS registry, there were 50%. And for women smokers nationwide, there were 35%, and for the ALS registry was higher, it was 44%. So the most common jobs held were teachers, healthcare workers, secretaries, salespersons, engineers. The most common industries belong to the construction sector. So they questioned exposure to welding, soldering materials, electrical current injury. There was increased rate of BMI reduction since ALS diagnosis, and this finding was consistent with past research. So 25% of those who answered surveys were veterans, and as opposed to 9% veterans nationwide. And 66% were never deployed to a war arena, so only a third of them were exposed or deployed to a military arena. 59% were deployed in Afghanistan. However, because of the younger age population of veterans studied, this led to an overrepresentation of veterans from Afghanistan war. So this was due to overrepresentation as opposed to exposure to a particular toxin in Afghanistan. There was no particular toxic exposure to elements such as DEET insect repellent or diesel fuel that was mentioned. So this was more of a descriptive study rather than a study designed to demonstrate causality. In summary, there are numerous epidemiological studies and systematic reviews of literature, but I found this fairly helpful, and this was published 2 years ago by Asterism and Mitsumoto. So I think we went through various levels of evidence. Level A meaning established risk factor, and as you can see here, it's male gender and smoking. Level B, which is probable risk factor for U.S. military service, lead, and pesticides. And the rest, physical activity, head trauma, electromagnetic radiation, low body mass index, statin treatment, and BMAA, are level U for the unknown. So after studying these potential environmental factors in ALS, I have made the following conclusions. One is there are many culprits with well-documented potential for toxicity. Lead is probably the one element that's most studied in the field. And yes, can lead attack neurons, spinal neurons, neurons in the brain, absolutely. But the story does not end with lead. The studies that I have come across were not designed to demonstrate causality. They were descriptive epidemiological studies. I think causality is based on known exposure, mechanism of action wherein a toxin engages a target and cellular function is compromised, such as what we discussed earlier about Mptp or synthetic heroin causing damage to dopaminergic neurons in the brains of Parkinson's disease. Or a toxin which is avoided, such as modifying the diet and not relying solely on L-sativus GRAS-P for protein source in Laterism, and the disease rates decline dramatically. So what happened to the Guam story? Guamanians, people living in the Key Peninsula of Japan and West Papua New Guinea, 60 years later, they find that the disease has declined slowly but surely and almost disappeared. Now it brings to light the role of environment as well as the role of genetics. So what they found was that the C9orf72 repeat expansion partially accounted for the high prevalence of ALS in the Key Peninsula of Japan, but no more than 8 to 10%, which is what we would expect. The most recent gene hunt in the island of Guam from 2015 found that 20% had genetic mutations such as FUS, fusin sarcoma, and Alsin, but again, 80% did not have pathogenic mutation. So to end this, I believe that history tells a story and the genes do not tell it all. There was a question that came from this side earlier from Barb Newhouse. And this is a question that's been asked in the clinic by a young mother with young children, asking, between now and the time Radicava becomes available in the market to be prescribed, I don't want to wait that long. Why can't I get the drug directly from South Korea or Japan and have you as my physician prescribe it, oversee the infusion, and get me going in the process sooner than later, before it's too late? So I did research that question a little bit, and I asked MT Pharma the very same question during one of the webinars, which I wanted to share with you, because I thought it made perfect sense. As a physician, we're taught from day one of being a medical student, first do no harm. And then on day 365, we're taught, don't get sued. But it actually has underlying emotional tones when this question is posed. And it goes beyond being just a physician, but just being a human being. And the answer to the question is that, like what Dr. Berry said, you cannot guarantee the chain where that drug goes. And the scientific answer to that is that the molecule, when exposed to oxygen, at any point in time, from the time it gets out of Japan to the time that it gets delivered to your pharmacy, could actually allow for the proteins to become denatured and not be effective. So that's a fear, that we might actually be infusing a drug and it's not doing what it's supposed to do. And the other difficult question, the curveball earlier, that I wanted to answer before you asked me later, is that I have been asked about the use of cannabis. And again, that's close to heart if it makes some feel a lot better in terms of adjusting to a horrible diagnosis and going through life. And I did some background research on that. So I thought, well, how about figuring out if it truly has negative effects on our patients? There was one major question that I couldn't answer based on the literature that I looked through, and that was, what is the cognitive and emotional effect on an ALS patient who uses cannabis. And the reason that is important is because there are reports that cannabis may worsen patients who have an underlying bipolar disorder. And two, I could not find any literature to say that there are no cognitive dysfunction that could be worsened by using cannabis. And on those two very important considerations, I felt that as a physician, you are in front of a patient whose decisions every minute of the day count. Do I use my PEG tube? Do I use my non-invasive ventilator? Every minute is a life-threatening moment.